Good morning. We're about to begin. Raise your hand if you're able to hear me clearly. All right, this morning we're continuing with Medical Emergencies, Chapter 19, Endocrine and Hematologic Emergencies. And the focus really is going to be on diabetes mellitus and bleeding disorders and clotting disorders. Introduction. The endocrine system influences nearly every cell, organ, and bodily functions. Endocrine disorders can have many signs and symptoms. Hematologic emergencies are difficult to assess and treat. Your actions may be life-saving. Let's review the anatomy and physiology of the endocrine system. And I sent a URL link to a YouTube recording for the endocrine system. Sure that you review that, which goes into more detail as it relates to the endocrine system. The endocrine system is a communication system that controls functions inside the body. Glands secrete messenger hormones. Hormones are chemical substances produced by a gland. Endocrine disorders are caused by an internal communication problem. Glucose metabolism. The brain needs glucose and oxygen. And the brain is the only place in the body or only area in the body where insulin is not required for glucose to move into the cells. So everywhere else in the body requires insulin. Insulin is the key that opens the door to the cell. So it facilitates the passage of glucose into cells, and it will convert excess glucose in the blood to glycogen and store that in the liver. So the brain needs glucose and oxygen. Insulin is necessary for glucose to enter cells. However, that's not a requirement for brain cells. Without enough insulin, cells do not get fed. So if insulin is not present in other areas of the body, then the glucose will accumulate in the blood and it's not moving into the cells. The pancreas produces and stores glucagon and insulin. So alpha cells produce glucagon, beta cells produce insulin. The pancreas also produces somatostatin from delta cells. So there is an area on the pancreas known as the islets of Langerhans, and they have alpha, beta, and delta cells. Now, glucagon will be released from the liver when the blood glucose level is low. Sorry, not from the liver. Glucagon will be released from the pancreas when the blood glucose level is low. And what glucagon does is it converts glycogen that is stored by the liver into glucose. So that's the purpose of glucagon. Insulin, which is produced by the beta cells, will be needed when we need to facilitate the movement of glucose into the cells and when there is excess glucose. So when insulin is produced, it will allow glucose to enter the cells, and the excess is converted to glycogen and stored in the liver. The somatostatin, which is produced by the delta cell, basically regulates glucagon and insulin. So it's the regulator for these hormones. Now, pathophysiology. Diabetes mellitus, which is what we will focus heavily on. There are numerous emergencies that will affect hormone production. You're not required to know those for the scope of this course, but you definitely need to be familiar with diabetes mellitus, and there's actually two types of diabetes. So you have diabetes mellitus and you have diabetes insipidus. And diabetes insipidus affects the kidneys and antidiuretic hormone. Not going to focus on that one. Going to focus more on the one with the glucose issue. So diabetes mellitus impairs the body's ability to use glucose for fuel. It occurs in about 9.3% of the population. Without treatment, the patient blood glucose level becomes too high and it can drop too low as well. In severe cases, may cause life-threatening illness or coma and death. Complications are numerous. So there are numerous complications of diabetes mellitus. Can be cardiovascular issues, can be issues with the eyes, the kidneys. They can have vascular problems. Numerous issues can result from diabetes mellitus. So it's the inability of the body to utilize glucose for energy. You need to know the signs and symptoms of blood glucose that is high, which is hyperglycemia, and blood glucose that is low, which is hypoglycemia. Now, regardless, once a patient is a diabetic, whether they have type 1 or type 2, they can have issues where the blood sugar is too high, and they can have issues where the blood sugar is too low. When the blood sugar is too high, the effects are gradual, right? So the issues are gradually occurring when the blood sugar is too high. When the blood sugar is too low, the effects are sudden or acute. And a low blood sugar will kill a patient much faster than a high blood sugar. So hyperglycemia and hypoglycemia can occur with diabetes mellitus type 1 and type 2. Type 1 diabetes is the patient that cannot produce insulin. So a type 1 diabetic does not produce insulin. It used to be called juvenile diabetes because it's common in that age group. So this patient is not able to produce any insulin, so they have to take insulin daily. And it can be fast-acting insulin, it can be intermediate-acting insulin, or it can be long-acting insulin. But they need to take the insulin every day because their body doesn't produce insulin. The type 2 diabetic is the diabetic that can produce insulin, so they can produce insulin. The issue is either they are not producing enough insulin, or the insulin that is being produced is not working properly. So it's one out of the two for a type 2 diabetic. Either the insulin is not sufficient or it's not working properly. All hypoglycemic patients require prompt treatment. So if the brain cannot get sugar, the effects will be immediate. Right? You will start to see effects immediately, and that can cause significant complications for the brain. So diabetes mellitus type 1. It's an autoimmune disorder, and what that means is, for some reason, this patient's body doesn't recognize its beta cells. So it sees the beta cells as an invader and destroy them. So the patient doesn't. Mic is on. Who is that? The patient doesn't have any beta cells because their body destroyed them, and the beta cells produce insulin. So if they can't produce insulin, then glucose cannot move into the cells, with the exception of the brain. So it's an autoimmune disorder where the immune system produces antibodies against the pancreatic beta cells. Missing the pancreatic hormone insulin. Without insulin, glucose cannot enter the cell, and the cell cannot produce energy. Now, think about it practically. Let me draw a line. So let's draw a line here. Right. All right. Let's put some. All right. Let's put a cell. Let's put a cell on that side. All right. So this is the cell on the. That would be the cell on the right side. That's the patient right, not your right. So the cell is on the right side, the patient right. And let's put some glucose molecules on the opposite side. All right, let's use the. All right. Don't want to use red. All right, so let's put some glucose molecules. So this is glucose in the blood. All right. This is glucose building up in the blood. All right. So the diagram I have right now, on the patient right, you have the cell that requires the, the glucose molecules. On the the left, that's the patient's left, you have the glucose molecules in the blood. So this is a type 1 diabetic. The patient requires glucose, right? So the patient requires glucose to reach the cells, but there is not enough insulin to open the door so that the glucose molecules can pass into the cell. Now, what is going to happen is if the cell cannot get the glucose, the body is going to say something is wrong, right? And what the body is going to do at that point, somebody's mic, what the body is going to do at that point is it's going to trigger the release of glucagon. And glucagon is going to convert glycogen that is stored in the liver to glucose. So what is going to happen is more glucose will build up on this side. So we start to get more glucose building up, right? Starting to build up, but no glucose is entering the cell. Now, if that continues, what is going to happen to the blood sugar? That's a question. So if the glucose molecules continue to build up and not pass into the cell, what is going to happen to the blood sugar? Quickly, someone answer that question. Not a difficult question. Right, it's going to get high, right? So there will be a rise in the blood sugar. Patient will start to develop hyperglycemia. Now, the cell still cannot get the glucose molecule. So what is going to happen now? The body is going to go to extreme measures. So it's going to take extreme measures to produce energy. And then, so what is going to happen at this point is the body starts to break down fat. So it starts to break down the fat in the body. And as a result of that fat breaking down, we start to get ketones forming in the blood, which is going to cause the blood to become more acidic. So the patient is going to develop what we call diabetic ketoacidosis. So diabetic ketoacidosis will only occur in your type 1 diabetic patient. And when they start to get ketones forming in the blood, that's where they will start to produce that unusual odor on the breath. Now, if this patient has not eaten, so if this patient didn't eat properly, right, didn't eat a good sized meal, and they took their insulin and the insulin rapidly facilitates the glucose molecules into the cell, but it's not enough glucose for the cell. What is going to happen to the blood glucose level? So they didn't eat properly, took their insulin, the insulin rapidly facilitates that glucose molecule into the cell, but it's not enough. So the cell doesn't have enough glucose. What is going to happen to the blood glucose level? It's going to become low or it's going to drop. That's hypoglycemia. All right. So whether they have type 1 or type 2, they can have issues with an elevated blood glucose level or a low blood glucose level. Now, Onset usually happens from early childhood through the fourth decade of life. Immune system destroys the ability of the pancreas to produce insulin. Patient must obtain insulin from an external source. Patients with type 1 diabetes cannot survive without insulin. Patients who inject insulin often need to check blood glucose levels up to 6 times per day. Many people with type 1 diabetes have an implanted insulin pump. It continuously measures glucose levels and provides insulin. It limits the number of times patients have to check their finger stick glucose level. It can malfunction and diabetic emergencies can develop. Always inquire about the presence of an insulin pump. I do not recall seeing an insulin pump in Jamaica, but I have seen it overseas. Some persons will have the syringe for pulling up and administering their medications. Some will have an insulin pen. I have seen persons with an insulin pen in Jamaica. It's similar to an EpiPen. Most common metabolic disease of childhood. Now, with type 1 diabetes, it will produce the typical 3 Ps of diabetes. So with type 1, you'll get the typical 3 Ps, or I should say, anytime the blood sugar is going up. Anytime a patient has an elevated blood sugar, you'll get the 3 Ps: polyuria, polydipsia, polyphagia. Polyuria is excessive urine production. So because there's an excess amount of glucose molecules in the blood, water is being pulled into the blood to dilute that, and that will cause the cell to become dehydrated. Polydipsia is excessive thirst. They're losing a lot of water through their urine and water that is being pulled from the cells, and majority of the water inside of the body is inside of the cells. So the cells become dehydrated and the patient feels thirsty. So polydipsia is excessive thirst or drinking. Polyphagia, the glucose molecules is building up in the blood, it's not entering the cell. So the cell is not getting the food supply or energy supply that it needs. So the patient feels hungry. So polyphagia is excessive eating or swallowing. They can have weight loss, they can have fatigue. When a patient's blood glucose level is above normal, the kidney's filtration system becomes overwhelmed and glucose spills into the urine. And when glucose starts to spill in the urine, it will have a dark color. It's going to have a dark color. And if some of that urine spills on the ground, you will see ants moving towards it. Polyuria is frequent urination. Polydipsia is increase in fluid consumption. And polyphagia is severe hunger or increase in food intake. The 3 Ps, remember those. When glucose is unavailable to cells, the body turns to burning fat. This produces acid-waste ketones. As ketone levels go up in the blood, they spill into the urine. The kidneys cannot maintain acid-base balance because it is happening too fast. Patient breathes faster and deeper, so the kidney cannot maintain that. So the respiratory system is going to try and reduce that acidosis. So the patient is going to have a rapid, deep breathing, and they will have that unusual odor on the breath that is referred to as Cosmo Respirations. So Cosmo Respirations is unique to diabetes mellitus type 1. If fat metabolism and ketone production continue and it is not rectified, then the patient will develop diabetic ketoacidosis. Once the body is in a metabolic form of acidosis, it will decrease brain function. So the patient is going to have an altered level of consciousness. They can be unconscious. Patient will present with abdominal pain, body aches, nausea, vomiting. If not recognized and treated, then DKA can lead to death. When a patient with DKA has altered mental status, ask family or friends about the patient's history and presentation. Obtain a glucose level with a finger stick using a lancet and a glucometer. The reading is generally going to be higher than 400 milligrams per deciliter. And the normal range for blood glucose is 80 to 120 milligrams per deciliter. Some books will have 70 milligrams per deciliter. In Jamaica, millimoles is utilized more often than milligrams. No worries. If your device is giving you the reading in milligrams, simply divide it by 18 to get millimoles. If the device is giving you the reading in millimoles per liter, then multiply it by 18. But most of the glucose readings that you will be given, if necessary for this course, will be in milligrams per deciliter. That's what you're going to see on your questions. That's what you will be told when you're doing your scenarios. Now, type 2 diabetes mellitus, caused by resistance to the effects of insulin at the cellular level. Association between obesity and increased resistance to the effects of insulin. The pancreas produces more insulin to make up for the increased level of blood glucose and dysfunction of cellular insulin receptors. Insulin resistance can sometimes be improved by exercise and dietary modification. So this patient can produce some insulin, but there might be an issue with how the insulin is functioning, or it's just not enough. That's your type 2. These patients can be placed on insulin, but they are commonly placed on medication, tablets, to control the blood sugar. This patient will not get acidosis, and the reason is simple. They are producing insulin, so some amount of sugar will enter the cell. It's just not enough. So the body doesn't need to go to extreme measures because there is some amount of insulin that is entering the cell. What is going to be common with your type 2 diabetic is as their blood sugar becomes too high, the most significant issue they will have in acute stages is going to be severe dehydration. So that's the most significant problem with a type 2 diabetic. They're going to become really dehydrated. You don't have to worry about acidosis with these patients, but they're going to get dehydrated, significantly dehydrated. There are going to be other complications because as the body becomes dehydrated, It causes shifting of electrolytes. So the electrolytes that's supposed to be inside of the cell is going to end up on the outside of the cell, and that can start to cause issues with the heart, the kidney. So they're going to need other treatment when they get to the hospital. That's outside your scope of practice as an EMT. Oral medications are used to treat type 2 diabetes. Some increase secretion of insulin and pose a high risk of hypoglycemic reaction. Some stimulate receptors for insulin. Others decrease the effects of glucagon and decrease the release of glucose stored in the liver. Injectable medications and insulin are also used for type 2 diabetes. Often diagnosed at a yearly medical examination from complaints related to high blood glucose level, which usually includes recurrent infection, change in vision, numbness in the feet. Now, symptomatic hyperglycemia. It occurs when the blood glucose levels are high, the patient is in a state of altered mental status resulting from several combined problems. Type 1 diabetes, it leads to ketoacidosis with dehydration from excessive urination. In type 2 diabetes, it leads to non-ketotic hyperosmolar state of dehydration. It's a very long word for the type 2, but all it simply means is that the patient is becoming severely dehydrated. So if you see that fancy word, non-ketotic hyperosmolar state of dehydration, or hyperglycemic hyperosmolar non-ketotic coma, simply mean that the patient is severely dehydrated to the point that they cannot maintain consciousness. That's the issue with type 2 dehydration. Don't be intimidated by the big words. If an individual has hyperglycemia for a protracted length of time, the consequences of diabetes may be present. So over time, the wounds don't heal properly. They start to have nerve issues. They can have issues with the glucose molecules or type of sugar molecules getting into the eyes and causing damage. They can have issues with their kidneys, can have issues with gastric motility problems. When blood glucose levels are not controlled in diabetes mellitus type 2, they will get hyperglycemic, hyperosmolar non-ketotic syndrome, or coma. Key signs and symptoms of Hhns include hyperglycemia, altered mental status, drowsiness, lethargy. They're going to have severe dehydration, and that's the most significant issue for your type 2 diabetes patient when the blood sugar is too high. They'll have excessive thirst, the urine is going to be dark, they'll have visual issues, sensory deficits, they can have partial paralysis or muscle weakness, and they can have seizures. Higher glucose levels in the blood cause the excretion of glucose in the urine. Patients respond by increasing their fluid intake, which causes polyuria. Patient cannot drink enough fluid to keep up with the exceedingly high glucose levels in the blood. The urine becomes dark and it becomes concentrated. The patient may become unconscious or have a seizure activity due to severe dehydration. Now, symptomatic hypoglycemia. This is an acute emergency. When the blood sugar is high, it is gradual issues occurring. When the blood sugar is low, it is an acute emergency. The patient needs treatment as soon as possible or they will not make it. So symptomatic hypoglycemia is an acute emergency in which a patient's blood glucose level drops and must be corrected swiftly. Can occur in patients who inject insulin or use oral medications that stimulate the pancreas to produce more insulin. When insulin levels remain high, glucose rapidly enters the blood cells. If glucose levels fall, there may be an insufficient amount to supply the brain, and the brain needs a constant supply of glucose. The mental state of the patient will decline, and they can display all type of different behavior. Right? They can be combative, they can be very aggressive, they can display unusual behavior, they can be unconscious. The low blood sugar can lead to permanent brain damage. Now, common reasons for low blood glucose levels to develop: the correct dose of insulin with change in routine. So they're taking the insulin the way they should, but there's a change in their daily routine that is using up the glucose that's available very quickly, right? More insulin than necessary, so they took too much. Correct dose of insulin without the patient eating a sufficient amount of food. Took the right dose, just didn't eat adequately. Correct dose of insulin and the patient developed an acute illness. So they took the right dose, but an infectious process has developed in the body which utilizes a lot of energy and glucose. Hypoglycemia develops much more quickly than hyperglycemia. In some instances, it can occur in a matter of minutes. Now, signs and symptoms of hypoglycemia: normal to shallow or rapid respiration. The skin gets very pale and moist. There is diaphoresis or excessive sweating, dizziness, headache, rapid pulse. The blood pressure can be normal or it can be low. The patient will display altered mental status. They can be anxious, they can be combative, they can have seizures, they can have fainting episodes or syncope, they can present in a comatose state, they can present with weakness on one side of the body, and there's rapid changes in their mental status. This chart is a very good chart for you to commit to memory, right? It shows what happens at extreme levels, right? So hypoglycemia is quickly reversed by giving the patient glucose. Without glucose, the patient can sustain permanent brain damage within minutes. Now, patient assessment. Scene size up, ensure your scene is safe, take the appropriate standard precautions for yourself and your partner. Identify the mechanism of injury or nature of illness. Consider whether or not you need additional resources. So scene safety. Patients with diabetes may use syringes, be alert for clues, use standard precautions, question bystanders on events leading to your arrival, keep open the possibility that trauma may have occurred. determine the MOI, determine the NOI. After you have completed your scene size up, the next phase is your primary assessment. And the first thing that we do in a primary assessment is form a general impression of the patient and the environment. So we're looking at the age, the gender, race, level of distress, whether or not life-threatening complications are present that requires immediate intervention. We're looking at the environment for clues as to what could have possibly happened to the patient. We approach the patient, so you form a general impression, you approach a patient and you ascertain the patient's level of consciousness using your AVPU quickly. Based on the patient's response, you will be able to assess the upper and lower airway. And our upper airway assessment is we position, we ensure it's clear, look, listen, feel, simultaneously check for a pulse if the patient is not communicating. For the lower airway, we assess rate, rhythm, quality, and depth. So once there's chest movement, that evaluation comes before circulation. If there is no chest movement, then circulation comes first. Now, based on the assessment of the upper and lower airway, if management is required, we will provide the appropriate management for the patient. And if we're managing the upper airway, it's positioning, maintain with your airway adjuncts, suction as needed, be prepared to use your pocket mask or BVM. And the pocket mask will only be utilized if your BVM technique is not effective. For the lower airway, you will either be giving supplemental, high or low, or you'll be giving CPAP, or you will be doing positive pressure ventilation. Once you have made a decision to give any type of oxygen therapy, once you have a pulse ox available, you want to know the pulse ox reading on room air. Okay, so primary assessment. Form a general impression, airway and breathing. Patient showing signs of inadequate breathing, a pulse oximetry level less than or equal to 94%, or altered mental status should receive high flow oxygen, 12 liters to 15 liters per minute by a non-rebreathing mask if necessary. Hyperglycemic patients may have Cosmo Respiration and a sweet fruity breath that's unique to type 1. Hypoglycemic patients will have normal shallow to rapid respiration. Manage respiratory distress. And respiratory distress can be mild, moderate, or severe. If it's not corrected, it leads to respiratory failure. That's not corrected, it leads to respiratory arrest. For it to be classified as respiratory distress, it means that the patient has visible chest rise. If they don't have visible chest rise, it cannot be respiratory distress. Once we have completed A and B assessment, then next is your circulation. In circulation, we quickly scan the patient for any signs of bleeding. We will check the peripheral pulse if the patient is communicating. If they're not communicating, the central pulse. We will look at the color of the patient's skin. There are changes peripherally, we check it centrally. We're going to check the patient's skin temperature. Not trying to get an accurate temperature, we're trying to determine if the patient is exhibiting signs of shock. We will check for signs of dehydration, which is very important to your diabetic patients, and we will check for cap refill in the pediatric population. So circulation, dry, warm skin is associated with hyperglycemia. Makes sense. So as the patient becomes dehydrated, the skin gets dry. Moist, pale skin, hypoglycemia. The patient is more closer to a shock state, so you're going to say shock type signs and symptoms. Rapid weak pulse is associated with symptomatic hypoglycemia. Now, excuse me a sec. After you have completed your ABCs, at this point, you should know what your patient's GCS is. You should know if you need to do a rapid scan. You should know if you need to focus. And you should know if it's a load and go or stay and play patient. So transport decision. Provide prompt transport for patients with altered mental status and inability to swallow. Further, evaluate conscious patients capable of swallowing and able to maintain airway. After your primary assessment, the next phase is your history taking. Investigate the chief complaint, obtain history of present illness from responsive patient, family, or bystanders. If patient has eaten but not taken insulin, hyperglycemia is more likely. If the patient has taken insulin but not eaten, hypoglycemia is more likely. Carefully observe signs and symptoms to determine whether hypo or hyperglycemia or semic presentation is what the patient is exhibiting. Sample history, ask the patient these important questions. So these are some questions to consider. Do you take insulin or pills to lower your blood glucose or sugar? Do you wear an insulin pump? Is it working properly? Have you taken your usual insulin dose or pills today? Have you eaten normally today? Have you had an illness? Have you had any illnesses? Unusual amount of activity or stress? These are very important questions to consider. After your history taking, and your history taking skills need to be exceptional when it comes to medical emergencies. After your history taking, next is your secondary assessment. Physical examination, assess unresponsive patients from head to toe. When you suspect a diabetes-related problem, focus on mental status, ability to swallow, and ability to protect the airway. Vital signs. Use a glucometer if available and protocols allow. And every unit should have a glucometer on board. And you need to be familiar with the glucometer machine that you have on your unit. So you need to be familiar, check it often, make sure the battery is working, make sure you have a backup, right? Make sure you have a backup, and follow your protocols as it relates to using it. Hypoglycemia, respirations are normal to rapid, pulse is weak and rapid, and the skin is typically pale and clammy with a low blood pressure. As I said before, the patient that is having hypoglycemia will more present as if they're in a shock state, and that's why it is sometimes referred to as insulin shock. Hyperglycemia, because the blood sugar is so high, the most significant issue is going to be dehydration. So their skin is not going to be pale and clammy. So respirations may be deep and rapid, and they can present with that unusual odor if they are a type 1 diabetic. The pulse may be rapid, weak, and thready, and the skin may be warm and dry with a normal blood pressure. Portable glucometer. Study the operator's manual for proper use in the field. Know the upper and lower ranges at which your glucometer functions. Normal non-fasting adult and child blood glucose level range from 80 to 120 milligrams per deciliter. For neonates, it should be above 70 milligrams per deciliter. And I have mentioned to you previously, if you want to convert that to millimoles per liter, divide it by 80. You'll see millimoles per liter more in Jamaica. Reassessment. Reassess frequently, provide indicated interventions. Hypoglycemic conscious. Patient can swallow. If the patient can swallow, encourage a patient to take glucose tablets or drink juice containing sugar. Administer highly concentrated sugar gel if protocols allow. Provide rapid transport. Interventions for hypoglycemic unconscious patient. So if the patient is unconscious, the risk of aspiration exists. Patient needs intravenous IV glucose, which is dextrose, and it has to be infused now. So we no longer give 50% dextrose as a bolus. That can cause rebound effects and issues when the patient is recovering. So it's infused dextrose, and it's 10% now. Patients need intravenous IV glucose or intramuscular IM or IN glucagon, and glucagon will only work if the patient liver is functional. These are beyond EMT competencies. So what you need to take from this particular slide and the questions on this chapter, if your patient cannot follow commands and is unable to swallow, you will not be administering any glucose. That's the answer to the question. Let me repeat that. As it relates to this particular chapter and the questions that you will see on this chapter, if the patient cannot follow your commands and is unable to swallow, you will not be giving any glucose. That's the answer to the question on the exam paper. In the field, glucose can be given to a patient that is not responding, but it must be done sensibly, right? So it can be done, but you need to do it as if you know what you're doing. There have been quite a few cases where the patient came into the hospital diabetic and them face full of glucose and their mouth full of glucose. What are you doing? That's crazy. You're putting the patient airway at risk. So when a patient comes in like that with them face and mouth full of glucose, it tells me that the responder panicked. You panic, man, and you just start to randomly do stuff. So it can be done in the field, and this is just for the field. It has nothing to do with the questions on your exams. The answer for the question on the exam is it's contraindicated if the patient can't follow commands or swallow. In the field, if you're going to do it, so if you're going to give a patient that's not responding glucose, you're going to put that patient in the recovery position. So they need to be in the recovery position. You're going to put some glucose on a bite stick. You're going to wet it with some saline, and you're going to rub the glucose into the cheek that is closer to the stretcher. So not top cheek, the bottom cheek that is resting on the stretcher. Rub the glucose into the cheek and it will be absorbed. And the patient will wake up. This is something I've done several times in the field. So it can be done, but you need to do it sensibly. You can't be giving a patient that's not communicating glucose and you have their head in a neutral position. You're putting their airway at risk. So it can be done, but do it sensibly. When in doubt, consult medical control. If unable to test for a blood glucose value, perform a thorough assessment. Contact hospital to help sort out the signs and symptoms. Communication and documentation. Coordinate communication and documentation. Inform receiving hospital about the patient's history, how they presented, what you did based on your assessment findings, and whether or not the patient refused transport after symptoms improve, because sometimes that occurs. They get the glucose in the field, they start to wake up and they don't really want to go to the hospital. Now, emergency medical care for diabetic emergency. In the first world system, you have the oral glucose gel. You also have the oral glucose chewable tablets, and it can be in liquid form as well. In Jamaica, what I've seen a lot is the glucose powder, the one that we used to put on, well, maybe we still do, that we put on orange when people run. That's what I see a lot of in Jamaica. Oral glucose contraindication. If the patient is unable to swallow or is unresponsive, you're not going to give it. That's the answer to the question. Wear gloves before putting anything in the patient's mouth, and sometimes you may have to put a bite block. And what I use as a bite block is I'll use a oropharyngeal airway, but I'll insert it upside down so that if the bite, it's not all the way in the airway, it's just slightly past the upper and lower teeth. And if they bite down, that will block them from biting down. Follow local protocols for glucose administration, reassess frequently, provide transport. The presentation of hypoglycemia. Seizures should be considered very serious. Possible causes can be infection, poisoning, low blood sugar can cause it. Trauma, decreased level of oxygen, it can be idiopathic where they don't know exactly what's causing it. Fever or undiagnosed epilepsy in children. Seizures may indicate an underlying condition. Ensure the airway is clear, place the patient on their side, put nothing in the patient's mouth, have suctioning equipment ready, provide oxygen and artificial ventilations for inadequate breathing or cyanosis, and transport promptly. For altered mental status, may be caused by other conditions. So outside of a low blood sugar, other conditions can cause altered mental status. Poisoning, head injury, postictal state, or decreased brain perfusion. May be caused by diabetes complication. Use your mnemonic AEIOU tips. For altered mental status, ensure the airway is clear. Be prepared to provide artificial ventilations and suctioning if the patient vomits. Provide prompt transport. Misdiagnosis of neurologic dysfunction, symptoms mistaken for intoxication. So Sometimes we think that the patient is intoxicated and there's something else going on. Don't develop tunnel vision. Misdiagnosis: a diabetic patient confined by police is at risk. Look for emergency medical identification bracelet, necklace, or card. Perform blood glucose tests at scene if protocols allow. Diabetes and alcoholism can coexist in a patient. And the rule is simple. If you have a patient that you're not able to get appropriate information from, whether it's directly from the patient or family or persons on scene, make sure you include pulse, oximetry, pupil reaction, and blood sugar reading in your vital signs. Relationship to airway management. Patients with altered mental status can lose gag reflex. Vomit or tongue may obstruct airway. Carefully monitor airway. Place the patient in lateral recumbent position. Make sure suction is available. And that's it for diabetic emergencies. Let's move into hematologic emergency. Hematology is the study of blood-related diseases. There are 3 disorders that can create a pre-hospital emergency. You have sickle cell disease, which is a hemolytic disease. You have hemophilia A, which is a bleeding disorder. And you have thrombophilia, which is a clotting disorder. Brief review of the anatomy and physiology. Blood is made up of 4 components. Each serve a purpose. Red blood cells contain hemoglobin, which carry oxygen to tissues. White blood cells collect dead cells and provide for their correct disposal. Platelets are essential for clot formation. Plasma serves as a transportation medium. Sickle cell disease. It's an inherited disorder and it affects red blood cells. And as I said before, it's a hemolytic disease. So what that means is the red blood cells are being destroyed, or they don't live as long as they should, right? So they're being destroyed too quickly and the body is not able to compensate for that. And it will lead to inefficiency in oxygen being transported to body tissues. It's a sickle cell disease, so basically what happens is the cell is not formed properly. It has a sickle shape, a half moon. Well, I can't even say half moon. A half moon wouldn't be. Sickle is that thing that they used to cut here. Is it here? Old-time farmer people used to use it, right? But the bottom line is the cell is not properly shaped, and because it don't shape properly, it cannot facilitate the 4 oxygen molecules that is required for it to be properly oxygenated. So it's not oxygenated properly, and because it has the unusual shape, it doesn't move very well. So it will go to areas in the body and cause blockages, which can lead to complications. So sickle cell disease, inherited disorder. It affects red blood cells predominantly in people of African, Caribbean, and South American ancestry. People with sickle cell disease have misshapen RBCs that leads to dysfunction in oxygen binding and unintentional clot formation. Clots may result in a blockage known as vaso-occlusive crisis, and it can result in hypoxia, pain, and organ damage. Sickle cells have a short lifespan, and generally your red blood cells live up to 4 months, right? So red blood cells survive up to 4 months if they are healthy. Sickle cells have a short lifespan, resulting in more cellular waste products and contributing to sludging of the blood. Complications is anemia, and anemia simply means that the body is not able to get the oxygen that is required into the body tissues. And you have various forms or type of anemia. We're not going to get into all of that for the scope of this course. It can cause gallstones where the waste material is not broken down properly by the kidneys, and it results in not the waste material is not broken down properly by the body, and it results in acid crystals being formed in the blood that can damage blood vessels, and they can go to places and get stuck or clogged. Jaundice is liver complication. They can have issues with their spleen. Anywhere the blood cells go and they don't move properly or get stuck, it will cause complication. Patient can even present as if they're having a heart attack. So vascular occlusion with ischemia is common with these patients. So they can have acute chest syndrome, stroke, joint necrosis, pain crises, acute or chronic organ dysfunction or failure. They can have retinal hemorrhages, increased risk of infection. Many of these complications are very painful and potentially life-threatening. Clotting disorders now, hemophilia. It's rare, only about 20,000 Americans have the disorder. Hemophilia A affects mostly males, so it's a disorder where the patient is unable to create clots within the body. So they are prone to bleeding, and it can be a simple injury that results in significant blood loss for these patients. So decreased ability to create a clot after an injury, which can be life-threatening. Patients typically have intravenous factor VIII replacement. So that is what is missing, clotting factor VIII. So that they can get that via IV infusion, which helps the blood clot either close at hand or with them. Common complications of hemophilia A include long-term joint problems that may require a joint replacement. You can have bleeding in the brain, intracerebral hemorrhage, and they can have thrombosis due to the treatment. Disorder in the body's ability to maintain smooth. So this is thrombophilia now. Thrombophilia is the opposite. So this is a patient that is producing too many clots. So disorder in the body's ability to maintain smooth flow of blood through the venous and arterial system. Concentration of particular elements in the blood creates clogging or blockage issues. General term for conditions that result in blood clotting more easily than normal. It can be inherited, so it can be a genetic disorder, can be as a result of medications. So there are some birth control medications that can cause clots, excessive clot production. Patient with cancer, clots can spontaneously develop in the blood of the patient. They can have deep vein thrombosis. It's a common medical problem in sedentary patients and in patients who have had recent injury or surgery. You may encounter several methods to prevent blood clot formation, including blood thinning medication. And as I said, that term blood thinning is used very loosely in medicine. And really it's used a lot because the average person or citizen will more easily understand that term than the actual term for the medication. compression stockings, many mechanical devices. With DVT, risk factors include recent history of joint replacement. So a patient who recently had joint replacement and complains of leg swelling. Travelers, truck and long distance bus drivers. Bedridden nursing home patients. And any patient with a DVT is at risk for a pulmonary embolism if it dislodges. So you have to be very careful if you're transporting this type of patient. Very careful how you move them, very careful how you drive. You can drop in a pothole and that pothole can dislodge that clot and it's going to end up in the pulmonary vessels. Now we have a bigger problem to deal with. Treatment, anticoagulation therapy. Medications are typically administered for at least 3 months after diagnosis of a DVT. Patients prescribed medications to treat DVT are at increased risk of bleeding complications. A clot from the DVT can travel from the patient's lower extremity to the lung, causing a pulmonary embolus. Pulmonary emboli can cause chest pain, difficulty breathing, and sudden cardiac arrest if it is a saddle embolus. And this is a patient that you will see pulseless electrical activity in. If you see a PEA, it's common with these patients. Now, patient assessment. Not going to go through that again. When you're going through the PowerPoint, just pay attention to what you think is different. So anything that you think is new information, pay attention to that. I've already done the patient assessment earlier. It's the same patient assessment with a few key things to pay attention to. So let's focus more on the emergency medical care for hematologic disorders. Your treatment is going to be mainly supportive and symptomatic. Patients with inadequate breathing or altered mental status, administer high flow oxygen at 12 to 15 liters per minute by a non-rebreathing mask, place the patient in a position of comfort, and transport rapidly to the hospital. And that would be the end of this chapter. So that's diabetic and hematologic